Dr. S. Ramakrishnan, Dr. Reza Borwa, Dr. Tejbi Firowa, and Dr. Kimtika Balani.
I think we had a very scintillating talks, especially the orations, Dr. Neil, and then of course Dr. M.K. Das talk was very good, and then of course the oration by Dr. Kothari. So we will move on to the smaller subsets of lectures on PCI, and I always give, really I commend all the three speakers, Dr. Das, Dr. Neil, and Dr. Kothari. That's it. So we have our co-chairpersons will be Dr. Ramakrishnan and Dr. Kabala. And we have five topics here. First topic will be covered by myself, which is TEB and PCI. Second will be by Dr. Ravinder Singh Rao is here. Third will be Dr. Anindam Pade, then Dr. S.N. Bhupati and Dr. Ritu Una Korea. So it will be good talk, and I have to start my first presentation. So I move from chairing to the speaker's side. Dr. Ramakrishna will take over. So my first visit to Shillong, and I was very keen. I spoke to Neil, and he said, "Okay, why don't you come here?" I've been presenting many lectures all over the world. I'm also founder of the Indo-European course, and with blessing of Dr. M.K. Das, I'm also at the moment CSI Executive Committee member. The topic is drug-eluting balloons in percutaneous coronary intervention. We are not using this drug-eluting balloon too often, but of course there are specific indications where it will be used and should be used, and we are also using it. Personally, I'm also using quite a bit. Again, thanks to Dr. Amit Malviya and Dr. Neil Bordoi for giving us the opportunity to talk here. Topic is important, no disclosures. Before I give any talk, I always give to my mentor a salute to my mentor, Professor Alan Trivia, because I had a very special time with him when TAVI was being evolved. At that time, this is a few pictures which I want to share to everybody whenever I stay in 1996, 98. TAVI was not known, but it was in his mind and hypothesis. And then he started animal experimentation. I had a very special relationship. He has been to my house in Sarita Vihar in Delhi. The first picture, of course, my younger son, Dr. Kuber, is giving cycling. And we had very fond relationship. This was the first TAVI case which we did in November 2011, when TAVI was not available in India at the time. I took the patient from India to his lab in Rouen, where I worked. And this was the first patient who survived for 9 years later on. So coming on to my topic, this was my small emotional tribute to my always mentor. Revolutionary coronary intervention, coming on to this, we all know 1977, Andreas Grunzek did the first PTC in Germany. First angioplasty was done in Zurich, Switzerland. It's wrongly written, actually it was done in Germany. The slide is wrong. And then, of course, he became hero overnight. And you know that America was very smart enough, and they really took him. And in fact, I will not say bought him, but they made Andrews Grunfeld suit there. And he was shifted from Germany. He was a fellow in Germany. He was shifted from Germany to the United States. He had a very early death. He had a chartered plane crashed. He did not see all the further evolutions. We know that POBA leads to intimal dissections, and therefore we needed something more. Dr. Ulrich Segbert, my personal friend from Switzerland, did the first stent implantation in 1987. And very few people will know that Jacques Fion in France, he did actually in 15 days before he did a stenting, but this was not known to anybody, and publication came from Ulrich Segbert. So everybody knows Ulrich Segbert more than Dr. Jacques Paul in France, who did the first stenting actually, if you see the date timeline. But publication was more important. When you intimate, unless you do intimation to the publication body, you will not know. So this is what happened with Segbert and Jacques Paul. That's nothing important. Then, of course, bare metal stents were developed after Segbert, 1988. Julio Palmars and Richard Sachs developed a stainless steel stent for the coronary applications, and this was the big landmark, the second important landmark. But of course, it required for the bare metal stent. It had a restenosis, required pure antiplatelet. Many few will know that earlier it was ticlopidine rather than clopidogrel, which was being used for this. And before ticlopidine, they were only giving oral anticoagulant. It was actually the French trial, which showed must trial, MUST must trial, which proved the efficacy of diclofenac, which is an antiplatelet, different kind. But drug-eluting stents were, of course, the third revolution. This was very important, and this came up in 2002 and 2003 because they felt that there was a new incubable hyperplasia and the restenosis post-bare metal stent implantation. And this was known as Achilles heel for the angioplasty and stenting, and this was to the range of 20. Or of course, if you compare with the POBA, which is of course just the balloon angioplasty, it was much less, but still it was there about 10 to 15% cases had a restenosis, and that's why we needed something more. The anti-proliferating agent were infused onto the stent, and then this drug-eluting stent concept came up. And 2002 to 2003, the first introduced by the European and US markets, and in India also at the same time we started using drug-eluting stents in 2003. Something I remember at that time it was Cordis which was using it here. So restenosis post DS, of course, it was much reduced. And if you see this diagram of endothelialization and further and neoproliferation, it was much reduced with the drug-coating stent. Further important was that, of course, dual antiplatelets were to be used for more than 6 to 12 months. But of course, the fourth revolution, which was came, of course, was where this was a bioabsorbent stent, which of course became in controversial lines because of the increased stent thrombosis. And now we are not using that much. But this was considered to be a fourth revolution. So now coming on to the main topic, which is drug-eluting balloon, I have 7 minutes to left. Conventional semi-compliant angioplasty balloons. These are balloons which are semi-compliant conventional, covered with an anti-proliferative drug, which is released into the vessel wall during inflation of the balloon. Inflation usually at normal pressure with specific minimal inflation time. Active substance on the drug-eluting balloon has to be lipophilic, with high absorption rate through the vessel wall to compensate for the short period of contact between the inflated balloon and the vessel wall. Because you see, while you are taking out the balloon stent, when you're putting a drug-eluting stent, the stent remains there, and with the time for the drug to proliferate, so to prevent the proliferation of new internal proliferation. So this is only short inflation time. So the drug has to be highly lipophilic so that it can be absorbed. This is a component of drug-eluting balloon, active drug molecule, urea excipient molecule, which helps in this agent to facilitate the optimal drug delivery. And this is the agent, then the balloon, and the vessel wall. And of course, 3 microgram per millimeter, which is not so important technically otherwise for us. But this is the amount of paclitaxel which is used. And why paclitaxel? Because this is actually a very highly lipophilic molecule rather than sirolimus. And that is why paclitaxel drug-eluting balloons are being used as of now. So what are the promising indications? Clinical only in instant restenosis, in bare metal. Of course, nobody is using bare metal these days. So instant restenosis in drug-eluting stent is the primary indication, which is also approved by ESC guidelines. In, of course, de novo lesions, that means in small vessels where you cannot put a stent and you feel that this can be do better. I'll show you some clinical evidences. Smaller side branches and bifurcation. For example, if you have T1, which is small side, ostial, I have done many cases of this sort, and ostial origin, you would not like to put a stent, and you cannot want to jeopardize the main artery. The artery is more or less around 2 millimeter only, diagonal branch, for example, and then you would like to do a drug-eluting balloon. In patients with contraindication to prolonged dual antiplatelet, of course, their drug-eluting balloon can be used. So coming on to the why practice at a highly lipophilic rapid intracellular uptake and retention vessel wall for nearly a week, acts by reversal binding to microtubules, inhibiting cell division, shorter incubation time, 3 minutes with paclitaxel almost completely inhibits smooth muscle cell proliferation up to more than 12 to 14 days. This is actually histopathological study which has shown that it inhibits smooth cell proliferation for up to 12 to 14 days. Zacrolimus also lipophilic can also be used in DCT applications. First generation, there are 3 generations of drug-eluting balloon. I will go very quickly about this. The first one, Bayer, Germany, Suken Plus, where they use a drug carrier applied on balloon surface, which was iopromide, increases drug solubility and speed uptake. This is actually a drug carrier. Of course, paclitaxel concentration iopromide is 22 times than in saline. Second generation was paclitaxel again with hydrophilic spacer molecule urea. These are Eurocode Germany from paclitaxel, and of course Biotronic Germany. They started this different molecule for the for hydrophilic spacer molecule, which is urea. And of course the third generation is the no carrier, which is coming from Resonance Eschen Germany, and of course Blue Medical Netherlands. There's no carrier, very tight bound of paclitaxel in between balloon folds. Not so important technically, but it is just to theoretically cover the topic. The 3 types of drug, the DEPs are available. So there are different types and there are different formulations released from balloon surface, vessel wall, various companies, B. Braun, Medtronic, Eurocore, which is being used in India, Eurocore from Germany, and then of course Biotronic, Berlin. So these are different companies which are making this, and the type of coating is different. And in Eluting, there's no carrier. So it is only theoretically important for now, for clinically it may not be so important. What are the practical points before DEB use, drug-eluting balloon? Proper vessel preparation is very important. With pre-dilatation balloon should be 0.5 to 1 millimeter smaller than intended drug-eluting balloon. That means when you are doing a pre-dilatation, it's always important. It's always important, rather mandatory to do it. It is not like just direct stenting. You have to have a pre-dilatation, very well done. Ensure adequate one-to-one sizing between vessel and DEB. IVUS in coronary should be normally used. We are not using IVUS so often, OCT or otherwise. And IVUS in peripheral, but this is a guideline which has been said that, of course, you have to use IVUS to know the exact sizing of the vessel. Shorter transfer time from SSC to DEB. Only 3 minutes left. Single prolonged infusion for complete drug release in recommended time. So what are the, we'll discuss evidences in each category. Category with DB versus BMS versus DSS. These subjects. What are the different subjects? Instant restenosis, de novo regions, small size, less than 2.5 meter. Smaller size in bifurcation. I told you, for example, if you are bifurcating such a diagonal branch, which is also but it has shown this was clinical trial, DB versus POA, and if you can see 9% versus 40%. That's what of this. And this is very positive. See, please, DB versus every 12 months TLR, 6% versus 2% statistically. The randomized trial. Let us talk about the DPS. This is practically important. One trial which I would like to highlight is I discussed about groups, and they found that in DEB it was 22% TLR. I'm not talking about TLR. This was DEB was 22%, PES 13% in paclitaxel, and of course, which is not statistically significant. There's no impact. But of course, when you compare just a Eluting stent balloon, you have almost similar. Important trial, DEB versus PES, TLR 16 versus 8. This is not significant. You can use in instant balloon vis-a-vis a paclitaxel eluting stent. There is no doubt because the results are. And that is why ESC has shown drug balloon are recommended for the treatment of instant restenosis, whether it is through BMS or DES and class 1A indication. So this is what indication evidence instant restenosis. And of course, DES are also recommended for treatment of instant restenosis, but both are class 1A. So it's actually the operator who has to choose between DEB versus eluting DES. So coming on to the small vessels, these are very important categories because Indian diffuse disease, diabetic patients, that you have a smaller disease, and these are more subsets where you can actually use the drug-eluting balloon, where you feel that strength will not do good. So this trial, I have two trials. This is a randomized type of comparison: DEB versus PES, 60% diode balloon, bailout BMS. The MACE 35% was 13%. Of course, MACE was higher in the DEB group. Here the Bellow trial, DEB versus PSS, 7.8 versus this 13.2. The two different trials have shown different results. The second trial, which is 182, has shown that no significant, clinically significant, but in the group which is DEB versus paclitaxel eluting stent. So small, I know. So I will just small vessels. I told you about bifurcation. I've told you then bifurcation lesion. This is a small trial, just 30 seconds. ISR, if you see the MACE, 20%, 29%, 17%, and not clinically significant. What they've done, DEB in the main branch, side branch BMS, and main branch versus BMS versus POBA versus DES versus POBA. So this is T-stenting, provisional T-stenting approach, where they have not found any major difference if you are using a drug-eluting balloon, even bifurcation lesion. So the rest I will cover. To ESC guideline, unfortunately, 2014, I don't have the latest guidelines, but of course, it's a clinical operator who has to see if you are a smaller vessel, instant restenosis. If you are where you don't want to put a stent, osteodiagonal, you have to use drug-eluting balloon, and they do fairly well. I have one patient we also include it, but I have no paucity of time, where I have done a drug-eluting balloon in diagonal first front. Of course, we have done many in ISR, but where the patient has fared very well for 5 years follow-up is available. So to conclude, TEB is a promising technology in both coronary and peripheral artery disease, not suitable for all patients. For technical success, requires proper patient selection, clinical angiographic correction, and proper preparation of vessel. Very important. Proper preparation of the vessel is important, and of course, you have to have your own discretion vis-a-vis a clinical evidence. Thank you very much.
Thank you, Dr. Vivek Gupta, for such an exhaustive overview of drug-eluting balloon. We'll have the discussion at the end. So we now call upon Dr. Nagendra Bhubadi, who is a professor at SRMC Chennai, and he will be discussing about two topics: one on calcium modification in PCI, how to breach the barriers, followed by imaging.
All speakers are here. Don't answer. Amit, okay, good recording.